Good afternoon. I am Amrish Tiwari, editor publisher of Double Helical. It is one of the leading health magazine being published from Delhi NCR region. It's my kind privilege to host the today webinar on the topic of futuristic scope of robotic surgery. We have very eminent personality as speakers like Dr. Rajnish Malhotra. Dr. He is a vice chairman, Mac Super Specialty Hospital, Saket, New Delhi. Dr. Yes Kulati is one of the sports science injury expert, knee replacement, Apollo Group of Hospital, New Delhi. Dr. Kalpana Nagpal, she is one of the senior ENT surgeon and using the robotic surgery, first lady in the Intrust Apollo Hospital. And we have the Paki Agarwal, she is an oncologist, gynecologist, and expert in the robotic surgery. And the one of the prominent personality in medical fraternity, Dr. Arun Kumar Agarwal. He is the professor of excellence and director, medical advisor, innovation and clinical research in Trust Apollo Hospital. So I would like to request to Dr. Agarwal, please carry on this futuristic, our today webinar, futuristic scope of robotic surgery.
Thank you, Tiwari.
I hand over to you, please.
Thank you. Can you hear me clearly?
Yeah. Why not, sir? Carry on,
Great.
please.
So, thank you very much, all my colleagues, expert speakers who will be with us for next 1 hour, and all those who are hearing us, and all those who will be hearing us futuristically through various YouTube, etc. So today's topic is very interesting. This is a time when new technology development is coming up, and in this particular highly specialized technology which we are talking today, the robotic one. The robotic tool which was perhaps being discussed in the late last century, if I remember correctly, somewhere in 1985 was the first successful implementation, and then one by one, different places all over the world. This tool was developed more and more, and now when I talk about 1985 to 2025, 40 years, it has developed towards perfection. And what sort of perfection has this particular tool has achieved? What are the different clinical uses? We have identified few of the specialty. Of course, it has got uses in practically in all the specialties of medical science, but we have chosen only few. It is difficult for us to cover each and everything. And to start with, we are going to start with Dr. Kalpana Nagpal. Excuse me, I am a bit, you may say, I am also ENT surgeon, that's why I am choosing Dr. Kalpana Nagpal to speak first. Not at all, because I know she has to go somewhere else and speak. I know that. So Kalpana Nagpal is a senior ENT consultant, my colleague, and she is very dynamic lady ENT consultant. I'm purposely talking lady ENT consultant because she is the one who has created the first all India ladies ENT platform. So that sort of enthusiasm, and of course, besides routine ENT, she is the one, perhaps the first ENT surgeon who has picked up robotic intervention in the field of ENT. Am I correct? With this, there is a big introduction, but I think time will not allow us. I will request Kalpana, please tell us that in what way you are using robotic intervention and in which are the areas and where you feel that there is definite improvement in procedure.
Yes, sir.
Over to you.
Yes, sir. Thank you. Thank you for the introduction. Well, I would like to say robotic surgery is a kind of minimally invasive surgery. And how is it better than other surgeries is only when the patient clearly understands that there are certain advantages or benefits over the other surgery. Clearly, the outcomes are good and it has been proven over and over again in certain select conditions. So it's important to choose the case for surgery, and the surgical outcomes have to be equal or even better, and giving clearly more advantages to the patient. And that's how we convince the patients even. And first of all, there's a myth. Patients normally think that the robot is operating, but we'll have to tell them it's not the robot, it is the surgeon who's operating, only taking the help of robot. And it is basically for inaccessible areas. So in case of ENT, for example, in sleep apnea, so select cases of sleep apnea, whether it is mild or moderately obstructive sleep apnea, even in early severe sleep apnea, where the AHI is less than 50 per hour, or the NADR, that is the lowest oxygen saturations, are not less than 50, or the BMI in such cases is not above 35. So we're doing a clear case selection. In such cases, robot is very beneficial because the tongue base is the culprit in most cases. And so we are doing a midline glossectomy procedure along with epiglottoplasty or epiglotectomy, depending upon the need. And it can be combined with other procedures like palatoplasty, etc. So this midline glossectomy, without giving any external cuts, we are able to remove a chunk of tongue base, and that is giving us clear, improvement and functional outcomes. And there's a clear discrimination in the post-operative sleep studies. Post-operative sleep studies show improvement in all the statistics. Similarly, there are several other indications, like in hemangiomas of the tongue or the valvular or the glottis. The hemangiomas tend to bleed, whereas with the help of robo, first of all, you're able to access all these, benign lesions, even lower, much lower down in the throat without giving any external cuts. And there's no bleeding also, so there's no need to arrange blood transfusions, etc. And there are some other indications, like if a patient wants a cosmetically good outcome, doesn't want a scar in the neck, so we're doing even thyroid surgery. So scarless thyroidectomy is another indication. Now, these are some of the benign indications. There are a few more. And similarly, in malignancy, early cancers, early base of tongue cancers, or cancer tonsil, or cancer supraglottis, these cases, again, it's very beneficial. So without breaking open the jaw, you access the tumor directly and you do a wide resection of the tumor, and you even avoid radiotherapy and chemotherapy. So these are some of the indications. So if you want me to mention, there are a few more. So this is for basics.
Thank you, Kalpana, for sharing your views about some of the indications of robotic intervention. And I fully agree that in all sleep apnea surgery or all those difficult areas which perhaps routinely when we do difficult to reach, right? But at the same time, you said hemangioma. So do you think it helps us in reducing the total blood loss as a robotic intervention?
It's much more. Suction machines have been, dry at the end of the surgery. It's so gratifying to see. The planes are so beautiful that there's a precise dissection because of this 10 times magnification. You can see the tissue planes. There's complete excision of the hemangioma, and it's very neat. Otherwise, it's a messy surgery because you use bipolar cautery, and the elective procedures are messier as compared to robotic surgery. It's much neat and clean dissection. And as I said, even if they're lower down in the throat, no external incisions are required.
One thing more, we have been listening that perhaps for cochlear implantation, which is the in thing, but a technically difficult surgery, robotic intervention is coming up. Do you think soon we will start doing cochlear implantation with robotic help?
I hope so. It will start in India. In America also, it's in the very early phases, so they haven't done too many. So it has just begun. And yes, it's a futuristic thing. So robotic surgery for cochlear implant will be beneficial again, because everything is going to be under higher magnification. It will be easier to introduce those electrodes.
So my last question to you, Kalpana, do you think ever since you started your robotic intervention, and say sleep apnea, and the patient outcome has improved and the patient satisfaction? Can you give us some sort of figures?
Yes, sir. First of all, since as you know, like I was the first one who started in ENT, and overall worldwide also, ENT was the last specialty to start. So ENT is still in its infancy. So I've developed and modified my own techniques, and now I'm able to even proctor others because, you know, it's easier to understand how, for example, I devised the step ladder technique for dissection in sleep apnea. So it's much more helpful. You avoid the lingual arteries and you do a nice dissection until the petiole of epiglottis. And similarly, even other cases, like for example, we use something like FKW retractor for removal of these malignancies. The use of the retractor and docking and everything is a learning curve. We develop these over time, and now you know, we have trained staff, and similarly, I'll be happy to teach others also. Already proctoring a few, and yes, it is definitely learning curve for the surgeon also, and the outcomes have been very good. And even the duration of surgery and duration of stay in the hospital has much reduced.
Thank you, Kalpana. I think we had been following the Western literature, but I'm sure, though you are a senior consultant, for me, you are still younger. A young ENT surgeon like you will definitely create that much of data that we can not only share it with ourselves, but we can share it with the Western literature also. That is my wish. Thank you. Please be with us. There may be any question. My next expert speaker is our colleague, our friend, Dr. Yash Gulati. Good afternoon, Yash. How are you?
Good evening. How are you?
Welcome to this particular webinar. Dr.
Thank you,
Yash
sir.
Gulati is a very well-known senior ENT orthopedic surgeon in Apollo, Delhi. He is respected Padma Shri awardee. And Dr. Gulati has contributed a lot in orthopedic, but in the field of spine, joint replacement, sports injury. Perhaps he is one of the very well-known name all over the country and abroad. So with this introduction, Dr. Yash Gulati, we are talking about the robotic intervention in different specialized area, and in your area of orthopedic, when we talk about robotic intervention, we like to know your experience of robotic intervention, in which focused area of orthopedic you feel it has improved your results and your experience. We'd like to give us a verbal, or if you want to have some sort of slide presentation, but we'll request you to
Let me see if
make
I
it
can
within 10 minutes.
share just 3 or 4 slides. If it doesn't, then we'll keep talking verbally. You know. Let me see. Share. No, it's probably not working. You know. So okay, we can cancel. Anyway, so we can just talk. I think that'll be all right. I'm not able to share. Thank you, Dr. Agarwal sir and Amlesh ji, for giving me this opportunity to join this panel. You see, robotic surgery, my belief is that you have to run to be able to stand in this world. You know, if you do not keep pace with technology, you will be left behind. Now, see, when the technology is coming into being, I mean, then also my belief is that you should not be the first, you should not be the last. So let's see if the technology has proven to be useful, then you imbibe it. And as far as the robotic surgery is concerned, it's been there for over a decade now, and it has found to be useful. And that is why we decided to go ahead and become part of this revolution. And I'm happy that our hospital and I have been part of this solution for joint replacement with robotic assistance. there is no question that robotic surgery has increased our understanding of the problem, if not anything else. Because what we were doing earlier with mechanical, what is known as mechanical alignment with the instrumentation, and I actually used navigation also for many years, for about 7 or 8 years, and I felt that it had improved my results. And now robotic surgery is one step ahead of that. And we feel that the classification of arthritis that we knew before has also changed now. See, what new was the mechanical classification, and now we are talking of kinematic, and kinematic, and we have CPAC classification. We have phenotypes in classification, that every race has different type of phenotypes, and the alignment may not be the same for everybody. And this robotic surgery gives you an opportunity uh, to mimic the original alignment of the patient, not necessarily that you want to have a 0 degree mechanical alignment like we were doing before, or a 4 or 5 degree valgus, putting in a particular number calculated on the x-ray. So it may be very different. The functional alignment of limb may be very different for individuals, not only for race. So that's where it is going to score more than the normal type of alignment. And we have been doing that. Now, also when we use the robotic assistance, it we do a CT scan, the type of system we have. Some people do only with the C-arm or X-rays. The system we have is the Mako. We do a CT scan before. That data is fed into the robot, and it is calculated by specialized people who then design a 3D model, and then this tells you that this is the size, this is the site where you should be placing it, and this is the soft tissue balance that you have. And if we put the implant inside, how is that soft tissue balance going to be affected, and how much bone to be removed from which side, and whether or not we need a soft tissue release. If we do, how much soft tissue release. And this all data we have with us before we even enter the theater. So that is a very comforting thought, that this is what we are going to do, and this is what the robot is going to let you do, and is not going to let you go out of this range with this haptic technology that we have, and it will prevent accidental soft tissue damage also. So this is a great achievement, and my experience is that the amount of bone that you were removing before has definitely decreased with the use of robot. And the soft tissue that we were dissecting before, or we were releasing before, has tremendously come down with that. There's no question about it, because many a time there is a laxity on one side and tight on the other side, and we don't have to remove too much bone on the lax side, and remove actually much less bone than we would do otherwise. There were about 20% patients who were dissatisfied before, and we did not know the reason why they were dissatisfied. And it is now postulated that it was because the alignment was not mimicking the patient's own alignment. We were going with a set mind that either we are going 3 degree, 4 degree, 5 degree valgus, and that balance may not be right for that particular patient. Now, the data is coming in. Only in the coming decades we'll know whether this hypothesis or postulation was correct or not. And because this is being put in more precisely, it is expected that the expectancy of these implants will also be better, and it will be longer than before. So this operation will be more reproducible, less bone resection, less soft tissue handling, and knowing exactly what we are doing before. And the type of, you have to have different type of systems. There some are fully active, and then once you expose, the robot does everything. That I think is a little I find little this. And the semi-active one, which doesn't let you go out of the haptic boundary, perhaps is a better idea. And not only that, we can actually decide the type of alignment, whether we want mechanical, kinematic, functional alignment, whatever alignment we want, the robot lets you do that. And this is an advantage. The only problem is that this technology is expensive. The robot costs about maybe 5, 6, 7 crores. And there is ongoing cost. There is ongoing update of the software. We have to keep update with that. We need to have a MPS, the company guy who's trained in analyzing the data and gives you the feedback as to what we need. So this is a more elaborate procedure. And of course, also it needs, initially at least, takes definitely significantly longer time than the mechanical surgery that with the mechanical instrumentation, conventional instrumentation that we have been using. And other practical problem that we are facing is a very big problem, is that many of the insurance company, in fact, most of the insurance company do not cover this. And there are some insurance companies that if you do robotic surgery, they will not either reimburse the patient or reimburse only 20, 30, 40% of the conventional, which I find very bizarre. And I don't understand why this happens. And most corporate houses are also not covering robotic surgery. So that is a big challenge. That is why we are not able to do large numbers in with robotic surgery. Some hospitals are taking cash for the robotic part of it and doing it. Our hospital does not permit that, because our hospital feels this is not legal, because they are going to again ask for reimbursement and we'll get into trouble. So that's where we are. But the most important thing is that with the robotic surgery, we have understood many things that we did not know without using the robot. Now, for example, even if I'm doing a conventional surgery with conventional jigs, there are procedures which I'm able to do during the surgery, which I've learned because I use robot. For example, I might do what is known as a little more varus cut on the tibia, little more varus cut on the femur to open up the medial space. So these little tricks we have learned out of robotic surgery. So overall, it's a very good thing. My only problem is that we need to sort out this problem of the insurance and the hospitals, they taking extra money because of the cost of the robot. So this needs to be sorted. This is a very big problem in our setup.
Thank you, Dr. Gulati, for sharing your experience in the field of orthopedic, especially in the field of joint replacement. I fully agree. You say the costing part and insurance is an administrative issue, which I strongly recommend that should be taken care of by the policymakers and the decision maker. But perhaps on this platform, we are talking about the technicality. And the technicality is that as Dr. Yash Gulati agreed that the outcome of the patient, satisfaction of the surgeon, satisfaction of the patient, both are very important. When we finish our surgery, as a surgeon, you know you have done a good job, right? So you know that you have done a perfect job, and that will get reflected. But Dr. Gulati will like to, I know there are certain focused areas of yours, but do you think it is useful in spine also?
Yes,
And
yes, it's useful in spine. It is actually being used, but it's not the same robot. It's a different robot,
of course.
which is being
But
used.
idea is to convey a message to those. I mean, in orthopedic, I like to think about joint, I'll think about the spine, I'll think about the orthopedic oncology. And in complicated malunited fractures. What do you think?
I mean, it's not yet being used in that particular thing, but now we have 3D models, 3D.
Dr. Gulati, can you hear me? Dr. Gulati? I think Tiwari ji, Dr. Gulati का connection थोड़ा सा
That has been disconnected.
That's
Am
it.
I audible, Dr. Gulati?
Yes, I can hear you.
Your
Yes,
voice is-
for a minute you were not audible. There was some
Right.
poor connectivity on your part.
Sorry.
Please continue. You wanted to convey something regarding the utilization of robotic intervention in other
Yeah, I
important.
mean, ultimately, you see, if you succeed in one field, it will come into the other field. There's no question. But we are not using in any other field except for joints here. I'm not using in spine, but there are some surgeons who are using robotic assistant in spine also.
Right. So thank you very much, and please stay with us because there may be some questions for you, which will be.
Can I make a request, sir? If
Yes.
there are, I just need to be away. If there are any questions, please, if they can be asked now, as I requested Mr. Tiwari also before. I apologize for this.
तिवारी जी आप अपने को अनम्यूट कीजिए.
Sir, I have the question for Dr. Yes
So
Gulati.
then I will request only one question because.
Yeah.
All right. Sure.
Please. आप अभी
Sir, dear, this question goes to Dr. Yes Gulati. This question from Deepak from Chennai. Could you tell me in remote area where specialist doctors are scarce, do you think robotic assisted surgeons could be a game changer? If so, how can it be implemented?
I did not get the first part of your question. If the surgeons are scared, I didn't understand what you said.
इनका
In
कहने
remote area,
they want to
particularly
know.
the remote area, particularly about the remote area where especially doctors are scarce, do you think robotic assisted surgeons?
Scared.
Yeah,
They are in
In the
scarcity.
Scarcity. I
Yeah.
don't think I'm going to answer that question. In fact, it will be difficult to use this in remote area. Just the sheer cost of it will not allow you to use it in the remote areas. And robot is not a doctor. He's not a surgeon. He cannot do the surgery for you. So you have to have very well trained, in fact, better trained people for using the robot. And because the surgeon who is doing the surgery has to be extremely good in conventional surgery and then use robotic surgery, because I know of an incident in US. Somebody went visiting a hospital and there was a surgeon who was trained only in robotic surgery, and the robot stopped working. Then he did not know what to do, and he had to request his senior to come and help him. So that scenario cannot be allowed. You have to be extremely good in conventional surgery, and suppose robot will malfunction one of these days. It's a machine after all. So when it malfunctions, or maybe 1 in 300 cases, 1 in 500 cases, the surgeon cannot leave the battlefield. He has to complete the job with conventional surgery. And not everybody, not all cases can be done with robotic surgery. Some very complicated cases, revision cases cannot be done for the moment with robotic surgery. So you have to be extremely good. So I think the answer is that in the periphery, definitely this is not the answer.
I fully agree with you, Dr. Gulati. Robot is not a replacement. It is an assistive device.
Correct.
For surgery to improve the precision, for surgeon to improve the precision.
Correct.
Right? But for using the robot, surgeon has to be perfect, an expert.
Correct.
Right? So thank you, Dr. Gulati. I
apologize, sir. I apologize to all the speakers for having to go. I'm grateful for letting me go.
Thank you for joining us and have a good day.
Thank you, sir. Thank you.
Now I'm going to request a very important surgeon of a very important area, the cardiac. Cardiac surgery, so it's a basically doing surgery on the heart is one thing when as an ordinary person one gets scared of. But if needed, it has to be done. So we have Dr. Rajneesh Mehrotra. Dr. Rajneesh is a very eminent cardiac surgeon, a senior cardiac surgeon from Max Healthcare, Saket, and he has got more than 30 years experience. The best part of Dr. Rajneesh Mehrotra is that he is from King George's Medical College, and I'm also from King George's Medical College. So I feel proud of Dr. Rajneesh Mehrotra. Needless to say that he has achieved so much in cardiac surgery. He's a very eminent, and he gets referral cases from all over India and from abroad because of his expertise. Rajneesh, we'd like to share your experience of robotics in cardiac surgery, and very correctly, is it really useful? If so, your experience.
Good afternoon, sir. Hi, good. Thank you very much for giving me this opportunity. I really am being honored today, being part of this webinar. So, sir, I would like to share my slides, and are you able to see my slides, sir?
Yes, we can.
So I'll just go into the PowerPoint presentation mode.
Yes.
So, I will just be talking about robotics in cardiac surgeries. So basically, sir, as I would say, robotics started with cardiac surgery. In fact, that is the fact which not many people would know. Robotics all started for cardiac surgery, so that the complicated surgeries can be done very precisely and more accurately. So that was in 1997. That was the first robot which we called as ESOP. That was the one which was being used in cardiac surgery, and this was just a robotic arm which was holding the endoscope, and it was following the verbal commands. So we were giving verbal commands for this endoscope to follow, and that we started, and we were telling that, and the ESOP move in, move out, move right, left, so that we can, while the surgeon's hands are free, so by verbal command, surgeon can control this robotic arm, and then the robotic arm was helping us to manipulate the endoscope. And this is how the robotic surgery came into field in cardiac as well as in the medical field. And you will be happy to know that it was first started, as somebody was asking whether we can do remote surgeries or not. It was basically planned for the astronauts. NASA planned that we should be able to do, if suppose there are astronauts, there are space stations. In the space stations, if the people develop some kind of a problem, then how can they be managed? Because surgeons and people cannot be there, the doctors cannot be there, so how they can be managed while people are living on or performing procedures on Earth. So this is how NASA started with it, and now it has become, I would say, in future, robotic surgery is going to be the thing which is going to take over all fields of surgery. As of now, as we just heard about the ENT and orthopedics, it is being done for the urology, neurosurgery, pediatric surgery, oncosurgery. It is done in big way. It's done almost every single day, and gynecological surgery and ophthalmic surgery also. And in our cardiac thoracic field, we are doing a lot of cardiac surgeries with the help of robot. Because people think, it is just a myth. Robotic surgery it cannot be done. As I said, it started with cardiac surgery, but people found it to be a little difficult to perform complex cardiac procedures through robotic surgery. That's why, for a while, I would say for 10, 15 years, it was taken over by others. But now there is resurgence of this, and now cardiac surgery has restarted and reinvented, I can say, with the help of a robot. This is a conventional cardiac surgery where you have to cut open the bone. We have to do the sternotomy to perform the different cardiac surgery for valve replacements. We have to do bypass operation, and this is conventionally what we do. Patients do not want this, because once you do conventional surgery, patient has to be at home for at least for a month or so, month to 6 weeks. Patient has to be bedridden, and they are not able to perform their activities. So our patients want to return to their normal activities as quickly as possible, and so this is why robotic surgery came into vogue. And as we say, minimal invasive surgery transfers the pain from patient to the surgeon. So I mean, we have been doing minimal invasive surgery. We have been doing endoscopic surgery. So where we can have a 2D vision. I mean, where we have a camera, we put a camera inside the chest, and on a monitor we can do a 2D, see 2D images, and then we can perform surgery. It still, I mean, it gives a better visualization, shorter hospital stay, and reduction of incision is there, but it is still requiring rib spreading. We have to still spread the ribs. And we cannot really perform it so precisely as we can do with the open surgery. And again, we are looking in a small area, so surgeons get a surgical fatigue, and there is surgical assistance is limited, and that is why I mean the robotic surgery came into vogue. And there is a myth that it is not useful in cardiac surgery. I will just say that it is really useful in cardiac surgery. And another myth is that it is the Dr. Kalpana was saying the many patients have come to me and said that sir, surgery to hum aapse karane aaye hain. Why should robot be operating? A robot is just a tool. It just helps us to do this, and it really so that the surgeon is the one who is really performing the surgery. And we have got better control of the instruments. And many people say it is not as precise as open surgery. I would say it is more precise. It is not as cumbersome. You really need training for learning this. So most cardiac surgical procedures can be performed. Surgeon is total control of the robot, and it gives you a better range of movement. It is although expensive and requires learning curve, but I mean, I think that all can be learned with time. And about the cardiac surgery, so what all surgeries can be done through this is that we can do a mitral valve repair, mitral valve replacement. We can do a bypass operation. We can do intracardiac procedures like ASDs, atrial tumors like myxomas, tricuspid valve repairs. These surgeries are being done by us routinely. And then we do thoracic surgery like thymectomies, thoracic tumors, lobectomies, pneumonectomies, sympathetic nerve reconstruction, and very recently we did, and first time in India, dysphagia lusoria surgery, which is aberrant subclavian artery with the help of a robot. So what robot is basically? It's a console where the surgeon immerses himself into the robot, and he can see a 3D image, and we put the instruments inside the patient's chest, and surgeon need not to be at the bedside of the patient. Surgeon can be sitting remotely. And very recently, a cardiac surgery was being performed from Gurgaon. The surgery was being performed from Gurgaon, and the robot and other things were there in Jaipur. And there was one question just some time back. So that is practically possible, and you will be pleased to know this was done by an Indian cardiac surgeon, and this was done for the first time and with an Indian robot, which is made in India, entirely made in India. So this surgery was being done. So this robot, what I'm talking about, has got a vision system where the surgeon looks into the robot. It gives a 3D image. And these are the robotic arms which go inside the patient's chest. So whatever manipulation the surgeon does at the console are being translated inside the patient's chest. And these instruments have got dexterity that this has got move into 360 degrees. So you can move it all the direction as our hands can move, and it's almost like a human wrist. These instruments are very small, very precise. You can see the actual size of the instrument. It's a very tiny instrument which goes inside the chest. And these robotic arms which go through the ports, they are 8 to 10 millimeter ports, which are very small ports. So, and wide range of instruments are available. So this is a conventional surgery. You can say a conventional minimal invasive surgery where you have to perform surgery and the patient has to have a long recovery time for 8 to 10 days in the hospital. There is a big scar, patient have greater risk of infection, and this is the regular conventional surgery. This is what we do. And with you can say this is a 2D surgery or a endoscopic surgery where we still have to make a thoracotomy to put the valve and do the cardiac surgery and make different ports. But when we do robotic surgery, this all is taken care of. I mean, the incisions are small, and we just have to put a robotic arm there, and multiple surgeries can be done. As I said, we can do bypass surgery, we can do a valve replacement, repair, ASD, and different kind of surgeries. And there is no cutting of the bone, there is less blood loss, there is reduced risk of infection, less scarring, less hospital stay, and patient returns to their regular activity normally. This is IA internal mammary artery, which as cardiac surgeons we use regularly. This is a robot. With the help of a robot, we are harvesting internal mammary artery. This is a tumor, mediastinal tumor, which is there. With the help of a robot, we are taking it out. This is a dysphagia lusoria case, which is a very rare case where the aberrant subclavian artery obstructs the esophagus, where patient is not able to swallow food because the artery is going behind the esophagus. And with the help of the robot in a young 16-year-old patient, we did this surgery recently, and we could do it successfully. And then many patients have got the chylothorax, and this is the thoracic duct which starts leaking. So we can visualize this with the help of a firefly mode in the robot, and we can see this and ligate the thoracic duct. And this surgery can also be done. And this is a mitral surgery. So these are the only small 3 to 4 ports which are being put for performing mitral surgery. And this is a small video of a surgery which is done with the help of a robot. And this is the mitral surgery which is being done with the help of a robot. This is all done in our hospital. So you can see this is a electrocautery which is cutting open the pericardium, the outer covering of the heart, and through which we can see the different chambers of the heart. We can perform the surgery as precisely as we would be able to do through the open surgery. So these are the robotic arms. So we are seeing this as a 3D image. So we do it see it very precisely, and everybody in the room can also see the same pictures as the surgeon is seeing, so that you and everybody, the assistant who is at the bedside, also have the same visualization, same picture. This is what we do. So in the interest of time, I'll just skip this so that we can have a time for the discussion. This is another video. It's again a 6-7 minutes video, which I'll skip. This is
Rajneesh,
what
I'll
we get in
request
the
you
end.
to finish within a minute or two.
Sir, just 30 seconds more. This is what we get in the end. These are the only 3 or 4 small incisions, 8 to 10 millimeter, instead of a scar in the center of the sternum, and cutting open the sternum and doing it. These are the various robotic surgery which we have performed. This is a bypass operation, multi-vessel bypass done with the help of robot. This is a mitral valve replacement. This is a ASD. And this is again a multi-vessel bypass operation done with the help of robot. The surgeon is sitting on the robot and not next to the patient. And there is a assistant of the surgeon at the bedside, and we perform the surgery. And it is expensive, no doubt about it. But now we have an Indian robot made by Indian cardiac surgeon, SSI Mantra, which is almost 1/3 the cost of the robot, which is commercially available from US. So that is another very good thing, so that it will bring down the cost of the surgical procedure. Although it requires, it has learning curve, but surgeons who spend time in learning, they can very easily learn it. And for the patient, it's really a boon. It can really make the patient go back to their work and do everything much more faster than what they will do otherwise. Thank you, sir.
Thank you, Dr. Rajneesh. Of course, what I understand that after using robot intervention, you have improved in precision. You, as a surgeon, is more satisfied, and the outcome is better. And what else you want? And you could attempt all the difficult cases, which at times you could have said, sorry, I can't do it.
Definitely.
After all, there is a limit. And sometimes surgeon has to say, beyond my capacity. And that particular experience is perhaps now vanishing. I can't do it. We can do it. But also, we were concerned about the total cost of the robotic tool. And now you say that our Make in India product is coming up, which has got approval by the regulator.
Yes, sir. It is being used
Okay.
commercially. It
So,
is.
and that is the beauty of India. India is there always to give best possible care at the most affordable price. And that is the attempt of all my senior consultants like you. And that is what we are famous for. Thank you very much, Rajneesh, for
Thank you,
sharing
sir.
your experience in cardiothoracic surgery. And though that this time is very little, but sometime we'll have more detailed discussion. And now I am switching over to my next. And you did mention about the gynae surgery can be performed. And for especially gynae, we have requested our colleague, Dr. Pakhi Agarwal. Dr. Pakhi Agarwal is again a senior gynecologist with the Inprastha Apollo in New Delhi, and she has got more than 2 decades experience. After going through the entire experience, she also got involved into robotic intervention for last many years, and she has picked up this robotic intervention in gynae as she is very dedicated into this field. One thing more about Pakhi, I know that she is not only into the best possible intervention of gynae, but at the same time, she believes in holistic approach. So I appreciate your approach towards the disease. Pakhi, can I request you to take over and give
Yes.
your experience in your field?
Yes, sir. Thank you, sir, for that kind introduction. There are two things, two places where the robot has scored over conventional surgery, and I will highlight both of them, and both of which I am doing regularly. The first is patients of uterine cancer who generally tend to be overweight, they are obese, they are diabetic, they are hypertensive, they have a lot of comorbidities. And previously, the surgery that used to be done was open surgery with a big scar going from xiphoid to the pubic symphysis. Lymphadenectomies were done very extensively, and that led to patients having a very long recovery time and also lymphedema, which was a real problem, especially if the patients were obese. So robotic technology stepped in, and now for the last many years, the treatment for endometrial cancer has been standardized so much so that robotic surgery is now class 1 evidence superior and in terms of patient recovery and oncologically non-inferior to open surgery. So what I do regularly and what we are doing at Indraprastha Apollo as well is we do sentinel node mapping for endometrial cancer, where we utilize the Firefly technology of the Da Vinci system, and we map the lymph nodes which are most likely to be involved with cancer. We remove them, we subject them to the oncological tests, and it gives us the information that we need. And performing surgeries for patients who have BMI. Most of my patients, they have BMIs over 40. Most of them are in the age group of over the age of 60 years, 60, 70, 80-year-olds. So you can understand that open surgery has a lot of challenges anesthetically, recovery-wise. For these patients, their reserves are low. And of course, many of them have had previous surgeries as well. So in this subset, in this population with endometrial cancer, robotic surgery scores far over open surgery and definitely over laparoscopic surgery, which has a lot of limitations in obese patients. So that is one. And because their recovery is so fast, if they have to go on to the next stage of their treatment, which is maybe radiation or chemotherapy, they are able to start that without any of the complications, say, of wound breakdown, burst abdomen, and sepsis, and all of those, which are common in this subset of patients. The second place where robotics has a lot of role in gynecology now is fertility preservation. So women who have fibroids and multiple fibroids, we used to say at one time when we were training that if a lady has more than 3 fibroids and the cumulative size of the fibroids is more than 15, they should be going in for open surgery. Even laparoscopic surgery is a big ask. I myself have done many more than that, even in a patient. So the volumes we have removed, I mean, we've even published that data. So robotic surgery allows us to do that, to work very precisely, to separate the fibroid from the uterus, to preserve the myometrium, to reconstruct the myometrium, which is very important because here we are looking at a uterus which is not just structure, also functional. So to preserve functionality of the uterus, removing all the fibroids, robotic technology allows us to do that. There is a lot of precision, lot of magnification. Most of these patients don't even require blood because of how precisely the surgery is done. And I thank Dr. Malhotra for highlighting all the nuances of how the robot is better than conventional surgery, makes it easier for me to explain. So we hardly have any blood loss. Patients are up and about the same evening. They are allowed. So we have an enhanced recovery program that we follow at Apollo. And they start ambulating the same day. They are orally allowed the same day. Second, third day, they are usually going home. This is across the board, whether they are young, they are old, they have comorbidities, or they don't have comorbidities. So fertility preservation there, fertility preservation when it comes to large ovarian tumors as well. Also, so separating the normal ovary from the diseased ovary, separating it out, and again with oncological principles in mind, conducting that surgery. So in the space of gynecology, I think amongst all the other specialties, the robot has made a big dent in the landscape. A lot of women are now aware of it. They're asking for it. And because we see the difference in outcomes. And the other thing that some of my other colleagues might have highlighted, when we go into the abdomen and we feel gas, of course, it's not the same for cardiac or ENT. So when we go into the abdomen and we feel gas and we are moving instruments all around, one of the typical problems patients have, for example, after laparoscopies, they have a lot of port site pain. So wherever we have gone in, we have made those incisions, they have pain at those sites. In robotics, because the technology uses a lot of very complicated physics and a lot of things go at the back of it, these ports are nearly almost always painless. So even if we have done the surgery, filled the tummy with a lot of gas, done the surgery, removed the gas, removed the ports, these patients after the surgery sometimes even ask, did I really have the surgery? Because I feel I have no pain. In my mind, I thought I have an endometrial cancer. I'm looking at an 8-hour surgery with a long recovery time. And here I am next day in the ward walking about, eating, and now you are telling me to go home. So sometimes the Indian mindset is such that if we have cancer, we are in the hospital for 10 days. That is changing now. So, and we are able to offer that because we have the precision, we have the magnification, we have the skills to do that. So those are two places I feel, sir, in gynecology and oncology where robotics has made a phenomenal difference. Sir, you're muted, sir.
Thank you, Paki, for highlighting the role of robotic intervention in gynae, onco, and in the other important fields like fertility and all. Can I ask you one question? Do you think futuristically, or it has already come, any role of robotic intervention in obstetrics? In
Sir,
complicated?
I think probably it will never come because we do need to give that 10 centimeter incision to deliver the head. So while we are talking about less than a centimeter incisions, that is probably the only phase, the space in obs gynae where robot will not supersede, traditional obstetricians. Probably the only space, but everywhere else, complicated hysterectomies.
Believe me,
Where
as
can
a
be done.
routine delivery, I will never want robot to come. But in certain conditions where perhaps our obstetrician colleague do find some problem, there can be some solution.
Sir, there is a role for the robot here. Say women who are pregnant and they have an ovarian cyst, which does happen in pregnancy, and they need that cyst to be removed. That part can definitely be tackled robotically because we need very limited space to go in when we go in with the robot.
That's good. So overall, you agree that though the cost is more, obviously, and at the same time, we did discuss that as the time is passing by and we are trying to look into more innovative robotic versions of previous ones and make in India product. As I said before, that will bring down the cost as well as once now I strongly feel all my colleagues in front of me agree. It is not only you are recommending, of course you are recommending, but the patient is also perhaps strongly demanding, because the patients are very well read and they are demanding. But at the same time, if they are demanding and you also agree with them, then it becomes a double feature. Then you have to do. Your experience, Dr. Rajneesh, the patient is coming to you.
Yes, sir. Patients do ask for us. I mean, they come and they always ask me for robotic surgery. They always want their valve procedures, their bypass operations, and their ASDs and all these things to be done robotically. So patients really ask for it.
Kalpana, what is your experience that the patients are demanding now? Kalpana, unmute yourself. Unmute yourself, Kalpana.
Sorry.
Yeah.
Yeah, I feel a lot of awareness is required, sir, but now, just yesterday I operated on a pulmonologist who has sleep apnea. And there were some doctors from Malaysia, 2 doctors whom I operated. So slowly the awareness is increasing and people are able to understand it's really giving benefits. So hopefully we can do in large numbers. Yes, consumables cost is still a challenge. Hopefully that comes down and hopefully we can do large numbers. But yes, slowly the graph is rising.
Great. So we had wonderful discussion before I hand it over, because we had discussion in the field of obs-gynae, in the ENT, cardiothoracic, and orthopedic. Of course, there are other areas also. I would request Tiwari to discuss those areas also, especially urology and all. And we had a wonderful discussion. There may be few questions.
Yeah.
For I and from my side, let me say my thanks to Mr. Amrish Tiwari, my friend, who started this Double Helical magazine 10 years now. It is going to be 10 years, and this magazine is really coming up as a very important piece of information for medical specialists like us, as well as for the public and everybody in society. I wish all the best to
Thank
Double
you, sir.
Helical, and over to you for question answers, Tiwari.
Yes, this
My
question,
sincere thanks to all my friends,
okay.
colleagues for joining me.
This question
We'll
goes
meet
to
again.
Dr. Paki Agarwal. It's related to your field. Could you tell us this question from Minali Joshi from Maharashtra and Pune. Can robotic surgery help in complex gynecological procedure like endometriosis treatment and fibroid removal?
Yes, sir. So endometriosis, in fact, there have been now trials to say that it is even superior to laparoscopy. So endometriosis, again, you need magnification to pick out the smallest spots. You again, fertility, because most of these women who have endometriosis are infertile. So you need to preserve fertility. So endometriosis, definite yes. Robotics is far superior to even laparoscopy. Fibroids, as I outlined in what I spoke, when it comes to fertility preservation, especially in multiple complicated locations of fibroids at odd places, all of that robotics scores over conventional surgery. So yes, in both of these, as well as in complex hysterectomy. So any gynecological surgery per se, the robot has a very, very good role.
Thank you very much. Sir, this question goes to Dr. Rajneesh Mittal. Sir, could you tell me this question from Neha Verma from Calcutta? Many patients worry about the reliability of remote robotic procedures. How would you comment and ensure patient safety during a robotic surgery?
So remote surgeries have, are just being started. As we had just discussed, that remote surgery, but the surgeon has to be at the bedside as well as, the expert surgeon has to be by the side of the robot. So both the places, surgeons have to be there. I can understand the complexities there, but one has to be, both the surgeons have to be really expert, and it can be done. And as I said, very recently we did a cardiac surgery, from Gurgaon to Jaipur. So, but both the places, the cardiac surgeons were there. One cardiac surgeon was performing surgery in Gurgaon, the other surgeon was there at Jaipur, and it could be done. Because if the surgeons are expert at both the ends, I think there should not be any problem whatsoever. And it is the future. It can, because the many surgeries you can proctor that. A surgeon can be proctored, or if there any problem, expert can really always come into picture and they can tell about it. So this is, I mean, this is the practicality and this is the future.
Sir, as you know that with AI advancing rapidly, do you foresee a future where robotic surgery are performed without human surgeons?
I don't think so it will ever be possible, because the clinical decisions have to be taken. So clinical decisions, where to cut, where not to cut, AI cannot take a decision. So it has to be a surgeon, it has to be a trained person, because at the end of the day, we are treating human beings. We are not fixing machines. So once you are treating human beings, because every human being is different. Although I may be doing bypass surgery every day, but all surgeries, all hearts, all coronary arteries are different. So I mean, the clinical decision is how you are going to operate, what decision you have to take. And I mean, I don't think AI is going to take over that, but AI can help us in giving, I mean, a pre-planned thing that, okay, this is how we can, I mean, see a tumor. This is the thing, what we can pre-plan the entire procedure beforehand. And AI can always guide us. They can give us all the investigations and all while you are operating. This is also already been done, but I don't think AI will, take over entirely, and a robot will perform the entire surgery. Not in near future, I think.
Sir, this is my last conversation with you regarding this robotic surgery. As Dr. Esculati told us that most of the insurance companies do not cover the robotic surgery. So as a policy, as you already vice chairperson, chairman of the upper Max group of hospitals. So, and Dr. Agarwal also, you tell me that as a policy level, what you people doing your level based to most of the insurance company cover this robotic surgery in the worldwide, is a nationwide.
So we as a have, I mean, our hospital has represented and gone to many insurance companies and our healthcare providers as well as the government, so that they can, consider robotic surgery nowadays is not a cosmetic surgery, because insurance companies think that it's a cosmetic surgery. That's why, I mean, people have to spend more, and it's not a cosmetic surgery. It is something for the benefit of the patient, because the patient can go back to their work and have less pain and perform their day-to-day procedure, and they be more useful to the society.
It is
We are
there to
representing
improve
to the many
procedure.
companies, and hopefully, I think they have started covering it partially. The few companies cover it 50%, few companies are, and the insurance regulators we have approached from our Max Health Group, because we have got large number of robotic, the installations in our institutions. So they are considering it, and we are hopeful that they will be considering it as a part of the regular surgery, not as a cosmetic surgery, not as a luxury.
Thanks a lot, sir. And I am very grateful to join our webinar, the very hot topic, futuristic scope of robotic surgery. Dr. Agarwal, hand over to you, please conclude this.
I think we have already done so. So we had a wonderful discussion, all my friends, colleagues. And this is the topic which cannot be discussed in 1 hour.
Next time we will keep the
Yes.
one and a half,
Only
no,
other specialties, but at the same time, there are more specific detail of robotic surgery. So please, this is part 1, and you should keep part 2. Like nowadays, you are looking into serials, and part 2 serial, part 3 serial.
yes, yes.
तो आप इसका भी कम से कम 2-3 पार्ट और करके
Yeah, definitely.
cover up the whole robotic intervention.
मैं तहे दिल से शुक्रिया करूंगा, आपने एज ए मॉडरेटर वेबिनार को बड़े टैक्टफुली इसको कंक्लूड किया, एंड आई रियली appreciate the effort of Dr. Rajneesh Mittal,
Rajneesh
Dr. Paki Agarwal, Dr. Kalpana Nagpal, Dr. Esculati. Thanks a lot. Very, very shukriya.
Bye for now.
Namaskar to all.
Thank you, sir. Thank you very much. Thanks for this opportunity.
Thank you, sir.